Hello, everyone. My name is Professor Saika, and I'm going to be your professor this semester. I'm going to be teaching N240 to you all, which is the main focus of that N240 class is oncology, which is cancer. And to begin, I'm going to make this podcast for week one, which is going to go over the cancer basics. And hopefully, this will all be information that you guys can absorb and understand. And if not, as always, I am available for you to reach out to me via email and we can see about how to help you better understand this information. So, going ahead with our PowerPoint in regards to cancer basics. So, what is cancer? Which almost all of us have had the situation where cancer has affected our lives. But what is our understanding of what cancer is? What cancer is a multitude of different things, which is why you guys are in my class. But the main thing that a lot of people think of is rapidly multiplying cells, which ultimately causes death, which is partly true, but is not always true. There are multiple different faceted ways to treat cancer, and that is why we are going through this lecture. I also brought up this other thought is, who does cancer affect? This is important to think about because out of the entire world, out of the universe, cancer is one of those things that does not discriminate. It does not care how old you are, what color you are. It does not matter, your lifestyle, how you grew up. Cancer can affect everyone. And because of that, almost everyone is affected by cancer. Even if you say, I am not going to go into oncology, I'm not going to go into cancer, that is not my forte, if you will, the likelihood of you having a patient that has been affected by cancer is very high, astronomically high. So that is why it's important for us to have this within your curriculum and for me to be able to sit here and talk to you about this today. So what are the causes and risk factors for cancer? Causes and risk factors kind of go hand in hand. They are either the internal or endogenous causes or the external, which is more modifiable. And the internal causes are kind of what I touched on, were your age, your genetics, your race, your ethnicity, things like that. Where the external risk factors are more of those modifiable ones. Like we all know, smoking tobacco causes cancer. That is why we tell people very strongly not to smoke. And with that comes the education of not smoking, not chewing tobacco, not vaping, anything like that. So looking through this, radiation, that includes the sun UV rays as well as tanning beds. The more times you participate in things like that, the more times you go outside without sunblock, the more likely you are to develop cancer. You may look down here and say sexual practices. Yes, this can include multiple partners, history of sexually transmitted infections, things like that can lead to different cancers. One of the main ones is HPV. That can sometimes lead to uterine, ovarian, different types of cancer, cervical cancer, things like that. Psychosocial, that can lead to the decreased screenings or doctor's visits depending on how someone lives, what their economic status is, as well as it can lead to mental health issues. A lot of patients who have mental health issues don't always seek the medical health that they may need when something arises. It could cause an increase in risky behaviors, as well as put them at a higher risk for not being examined and assessed more frequently. So looking at the different viruses that are risk factors for developing cancer, I had brought up HPV, which, as I have here, it gives you that higher risk of developing cervical cancer or other types of cancers. Another big one is HIV. A lot of patients that have HIV later develop this lymphoma or sarcoma. So, with risk factors, we also like to talk about carcinogens. So, those two terms can be interchangeable at times, depending on how you're, what you're discussing, how you're talking about them, things like that. Carcinogens are the cancer-causing agent that results in a mutation of your DNA. So, what that means is that you come in contact with something that will alter your cell's DNA, which then can lead that altered DNA or mutated DNA to then continue to multiply, and then it develops into cancer. In the photo that I have right here, it explains the different degrees of carcinogens. For example, you can see, UV or sunlight has been found to be carcinogenic, as well as tobacco. Those carcinogens have been studied and have been found that overexposure to UV sunlight, overexposure to tobacco inhalation, or other types of tobacco exposure does lead to DNA mutation, which in turn can lead to cancer. There are other types of things that could possibly be considered a carcinogen, but have not been studied enough to find that they are most definitely going to cause DNA changes. So those are, caffeine intake, hair dye, different things like that. So when a carcinogen is introduced into the body and into the DNA, then it can cause that mutation in the DNA, the mutation in the cells, and then that is called carcinogenesis. So carcinogenesis, what that is in phase 1, it's the initiation. The carcinogen, which we just talked about, is that initiating agent. Tobacco, sunlight without UV sunlight, without any SPF on, no hats, anything like that, damages the DNA. The DNA repairs itself, which is one of the things that could happen after that phase 1, or the DNA mutates, but then does not cause cancer. It's just a mutated gene, or the mutation occurs and produces cancer. So that is all kind of in the first phase of carcinogenesis. So in the first phase, you're initiated, you're having that initial contact with the carcinogen, that initial contact with tobacco. Then your DNA gets damaged, but it can fix itself. The DNA mutates, but doesn't mutate far enough to cause cancer. Or lastly, it does mutate, and then the DNA does start to multiply and cause cancer. Phase 2, that's the promotion. So carcinogens cause the mutation. Once that mutation happens to the DNA, the cells in the DNA cells continue to rapidly divide. And that speeds up the expression of the mutation. So your DNA cells divide anyways, but once there's that abnormality in your DNA, they start to divide even quicker. And then that causes the increased proliferation of cells. I'm going to apologize if you hear any barking or anything. I do have a dog, and she is in the background, not necessarily behaving. But hopefully that'll be to a minimum. But back to what I was saying about carcinogenesis, phase 2 is the promotion of those abnormal cells. And then lastly, we have phase 3, that is metastasis. So that means that the cancer cells are secreting enzymes that allow the cells to eat through tissue and blood vessels in order to grow, to move, to go to other organs. The large bulk of the tumor can press against organs, causing issues, other types of things. So that is kind of how the cancer develops throughout your body. There are different phenotypes of cancer cells. So what a phenotype means in the context of cancer is it basically means the characteristic of the cancer cells. So specifically any observable characteristic or trait of the cancer cell that you can see under a microscope, such as the morphology, the development of the cancer cells, the biochemical properties, cell behavior, all of those things are the characteristics or the phenotype of a cancer cell. So the different ones we have here, we have the self-sufficient growth signals. So what that means is those are tumor cells that grow even when they are not getting a message to grow. So they are self-sufficient at growing, at growth. Number two is the resistance to anti-growth signals. What that means is that the tumor cells, the cancer cells, ignore the messages from the DNA, from the body that is telling it to stop growing. So the cancer cell has this ability to just ignore any other signals and continue to grow. Immortality, what that really means is the normally programmed cell death, which is apoptosis, is essentially ignored, leading to the accumulation of damaged cells. It ignores the signals telling it to die, telling it that it's time for it to be done growing, and in turn, it just continues to live on and multiply. The resistance to cell death, essentially all malignant cancer cells have this. It is a limitless replicative potential. And eventually it picks up more and more mutations. So, it has that resistance to cell death, and then it just continues to reproduce and reproduce. And then the more it reproduces, the more likely there are going to be more mutations within those cancer cells. Sustained angiogenesis. Angiogenesis is the development of blood supplies. So a lot of cancer cells have the ability to make new blood supply pathways, so new vessels that lead to the tumor. And in that way, it causes it to always have that food source that keeps the tumor growing. And then there's also the invasion and metastasis characteristic of a cancer cell. So that means the spreading of the cancer cells to other parts of the body, and it invades other organs, major organs, the lymph system, different things like that. One thing that I wanted to bring up at this point is thinking about the risk factors, the different causative agents of cancer, and then the way carcinogenesis happens. We get that mutated cell, and then that mutated cell starts to divide, multiply, and continue to grow. And then it has those characteristics of not stopping, ignoring the stopping signal, not listening to programmed cell death, metastases, all of that. So that's when we need to teach our patients, and for you guys to know the acronym CAUTION. That is one of the first things that you should think about when something seems different and could be a warning sign of cancer. So how I have it written out here is CAUTION. C is for change in bowel or bladder habits. If you find that your patient says, all of a sudden they are having loose, bloody stools, the blood alone would be a red flag. But, loose stools frequently, doesn't ever have a solid stool, that's some concern. A sore that doesn't heal. So that doesn't mean, you keep getting a rash here, there, what have you. It means it's an open area that no matter how many times you've put, like a Neosporin on it, you keep it covered, you don't pick at it, it won't heal. Unusual bleeding or discharge. We kind of talked about this with the bowel habits. If you have unusual bleeding in your bowels when you urinate, vaginal bleeding, as well as bruising, anything like that. T, thickening or lump in breast or elsewhere. If you start to feel a lump, if you start to feel an area growing, even if it's soft, smushy, or hard and firm, that is definitely a cause for concern. Ingestion or difficulty swallowing. A lot of times patients won't realize that they're having difficulty swallowing. They might think, oh, I swallowed something like a pretzel that was sharp, something like that. I actually had a patient that for a long time thought he was choking on a sunflower seed. He ate a sunflower seed and it happened to cause him to have this cough, and it caused his voice to kind of change. And after about 3 months, he then went to the doctor, and the doctor found that he had head and neck throat cancer. And so with that, he thought he was just got this sunflower seed lodged in his throat, and it happened to actually be cancer. And then O for obvious changes in warts or moles. When we go through the skin lecture, you'll learn another acronym, the ABCDE occasionally, which is any changes of moles. If it's not circular, if it's raised, if it's different colors, if it's growing, things like that. Any moles, warts, beauty marks, things like that. And then N, any nagging cough or hoarseness. Again, this kind of leads back to my gentleman that, had a cough, had some changes to his voice, and it did end up being a tumor that was pressing in on his esophagus. Now, this brings us to our case study for today's lecture. This is our patient, John Jones. He's coming into our clinic, our doctor's office, with the complaint of a dry cough. He is a 58-year-old male. He's African American and he is divorced. He has the history of working at the Hollywood Casino for about 10 years. He's the supervisor and dealer of table games. He does reveal to us that he is a smoker, that he has smoked for the past 20 years, about 3 packs per week. We ask him if he's thought about stopping. He says he goes back and forth, but because of working in the casino, there's cigarette smoke in there, and they occasionally put him in the cigarette smoking section. So he can't really seem to quit and stick with quitting. He is coming in specifically with the complaint of a dry cough that he's had for the past 5 months. He tells us that it won't go away. We ask him, what does that mean? He said he's tried cough drops, cough syrup, honey and hot tea, different things like that, and nothing really seems to kick this cough. He does also reveal to us that he's lost 20 pounds in the last 3 months. He makes the comment, I could use to lose a few pounds, but he does say that he has not been trying to lose the weight. Through our assessment, he's not having any shortness of breath, no chest pain. He says he hasn't had any recent infections such as COVID or the flu. He just really wants to see what we can do about this cough, give him something to get rid of the cough. So with all of that being said, I want you to think back on what we were just talking about. Specifically, one of the last things we talked about was the caution warning signs. His would be the nagging cough. That just doesn't seem to go away. That right there, especially for it going on for 5 months, is a warning flag that sticks out to me. Especially with his history. We talked about different risk factors. One of his main ones is smoking, that he has been smoking for 20 years. Not only that, but his work environment, which he doesn't necessarily have the option to change because it's his job, it's his income, it's what helps his family. There are areas of the casino where smoking is allowed, and that's where he says he does get put sometimes. One of the things that I didn't go into too much detail was the risk factors that are non-modifiable. For him, it would be being a male, and specifically an African-American male. Studies have shown that with race, ethnicity, African-American males have the higher prevalence of lung cancers. And so that is a risk factor he can't change, but it does put him at a higher risk. So with all of this, and the unexplained weight loss, one of the typical signs of cancer, which I will go into detail the further we go through this year, is unexplained weight loss, especially in patients that aren't trying to lose weight, but are having a significant weight loss, a lot of pounds in a short amount of time. So what is next? So with John Jones, we bring him back, we get all this information, we talk with the doctor. That then leads us to what would we do next? that would normally be some type of non-invasive testing. Normally, one of the first things doctors would do in a situation like this is they would do some type of lab test. With lab tests, a lot of times they'll do a variety of them. They'll get your normal CMP, which shows your electrolytes. It can show kidney levels. They'll get a CBC, so that's going to show your hemoglobin, your hematocrit, your platelets. A CBC with differential will show, your different neutrophil numbers, your white blood cell numbers, different things like that. More specifically, in a situation like this where we think it might be some type of cancer, we can then go into more specific lab tests for cancer. Those include LFTs, which would be for liver cancer, because those are your liver function tests. We could also do a PSA, which is for the prostate. That would assess prostate cancers. There are also some more generic cancer lab tests that we could do. That would be a CEA. It's typically a late indicator of cancer. It can be normal during the early stages, and then as the cancer develops, it becomes more prominent, more effective. Not effective, that's not what I meant, but more prominent, then the CEA number will be higher. A lot of times the CEA number is not specific to any type of cancer, so it doesn't really tell us, if it's prostate or lung or liver or breast, but it can tell you that there are cancer cells in the body. And then a little bit more invasive would be genetic testing. That's something we would normally do once we have the diagnosis of cancer. But genetic testing could be like the BRCA1 and 2 for breast cancer, and such things. So we decide that we're going to get some lab tests on him. After looking at the lab tests, whether they're inconclusive or they show some high numbers, the next type of testing would be diagnostic testing. With diagnostic testing, normally the rule of thumb is going from non-invasive to more invasive, as we're able to rule out different processes, different diseases. So we do the blood test because that's not too invasive. It's easy to get blood drawn. Then we move to more of the invasive. That would be like our ultrasounds, our CTs, our MRIs, PET scans, different things like that. Normally the ultrasound that works by emitting high frequency sound waves, and they echo back to the ultrasound machine off of different body tissues. So different tissues, fluids, gas, those all bounce back different wavelengths using an ultrasound. That one's easy. It's quick. Even some of you that work in the hospital may have seen like a bladder scanner. That is a type of ultrasound device. Another one that's a little bit more invasive is a CT scan that is used to combine a series of X-ray images taken from different angles around your body, and then it goes through this computer system, and it uses cross-sectional images to better visualize parts of the body, specifically bones, blood vessels, soft tissues. So that can kind of help us see where something might be more dense, that soft tissue might have more cells in that one area. And then the MRI really shows you the most out of the three, and that really is useful for, again, looking at those soft tissues, getting that magnetic imaging through there to kind of see what lights up. Speaking of lighting up, that would then lead us to maybe considering getting a PET scan. So what a PET scan is that is a scan that a lot of cancer patients will get, and it's one that kind of helps tell us where in the body cancer might be, if it's metastasized, any type of tumors. So basically, a PET scan is an imaging test that can help reveal the metabolic or biochemical function of your tissues or organs. Essentially, it uses a tracer drug or a radioactive drug that is taken into normal cells and abnormal cells. And when we do the PET scan, that tracer drug lights up. So when your normal cells light up, it'll be kind of a dull color. But when it's a cancer cell, there's a lot more activity inside them. So they light up brighter. And then that's how we can tell on a PET scan the bright spots are cancer. Other tests, again, those can depend on where the cancer is. And a lot of time, those are going to be your most invasive tests. And a lot of times, these ones are used for more type of biopsies. So like a colonoscopy, an EGD, a bronchoscopy. A lot of times when we scope a patient, you might have heard doctors or different medical professionals say that when we scope a patient, we will go down and we will also, collect a sample at that point. So that's when we would get a biopsy. So collecting a sample, that is where we can get some of the cells. And when we collect those cells, we are able to look at them under a microscope and see the specific cell types and characteristics. And when I say we, I mean the laboratory technicians and things like that. We normally just kind of look at them and use them to see if the patient has cancer or not. And again, that would come down to a doctor's diagnosis. Nurses don't diagnose cancer. So we would use the diagnosis of a biopsy to diagnose if a patient has cancer. So through the biopsy, there's different information that we gain. And that kind of depends on what type of biopsy we do. There are the three main ones that I kind of want to touch on. Those are going to be a needle, an open, or sentinel node biopsy. So the needle biopsy is an aspiration of fluid or an aspiration of tissue. A lot of times, a needle biopsy, they'll call it a bone marrow biopsy, because what that does is it aspirates tissues out of the bone marrow, and then we can test it to see if there's any mutations in there. You could also do a needle aspiration of lung fluid or tumor fluid. And then the next type is an open. So that would be removing a piece or all of a tumor with an incision. So an open biopsy would be just seeing that you have a mass or a lump or a lesion, and they cut some of it off, or they cut all of it off, and then they send that to testing. And then lastly, the sentinel lymph node biopsy. What that is removal of a lymph node near the cancer. And a lot of times we see this type of biopsy done with breast cancer patients. And it would be, if it's negative, the cancer has not spread to the lymph nodes. If it's positive, cancer has spread to the lymph nodes. And a lot of times, if it is in the lymph nodes, they'll take more than just that one. They'll take a couple. But for the most part, the more lymph node involvement, the further the cancer has spread and metastasized. So through getting the biopsy, that then the laboratory technicians are able to, and the laboratory specialists are able to look and better visualize the staging and the grading of the cancer. They look at it and then basically they decide, yes, this is cancer, or they see the mutation in the cells, mutation in the DNA, and that is cancer. But then to help us treat it, we need to know what the staging and what the grading of the cancer is. So, staging. I'm going to start with that aspect, because a lot of times when the normal everyday person talks about cancer, they talk about the staging of their cancer. Oh, I got diagnosed with stage 1, with stage 4. So understanding the differences is very important, especially when talking with patients about it. So through staging, it goes from stage 0 to 4. Stage 0 is the in situ cancer. And what that means is it's basically precancerous, but with a high enough degree of mutation in the cells that it's cause for concern. Some patients, they have this and they watch it. Other patients, they have this, they'll do surgery to remove the cancer cells. Other times they treat it with like a systemic chemo. What that means is a chemo that gets their whole system, and it's a powerful punch to make sure that that stage 0 doesn't advance to anything else. Looking over here at these stages of kidney cancer, this is a visual image to show you stage 1 through 4. So the staging determines the location of the cancer and the degree of any metastasis, if there is any. Stage 1, we can see that the cancer is only within the kidney. It has not spread typically, and it can be removed with surgery for a cure or for a good prognosis. It stays within the tissue of the original cancer organ. Stage 2, that is going to be cancer that is typically larger than 7 centimeters, but is still confined inside the kidney. Surgery is a good option for treatment, but may require other things such as chemotherapy or radiation. Stage 3 is a local but regional spread of the cancer. So stage 3, the cancer has spread past the kidney and to the outside aspects of the kidney, but it has not moved to any more distant organs. For example, it might have spread to like the fat outside the kidney, maybe some of the vessels that lead into the kidney, but it has not moved any further. Stage 4, that's where the cancer, specifically in our example here, the kidney cancer, has spread widely outside the kidney, including surrounding lymph nodes, which could be the adrenal glands or any other organs farther away from the kidney, such as lungs or liver. Touch on this slide about the progression of cancer. I believe that this image is a very good representation of what the different parts of cancer and the development of cancer looks like. So the growth of a tumor, so this is specifically for a solid tumor or a mass or a lesion, something solid, not a blood tumor, not a lymph type of tumor, but a solid tumor. So the growth of a tumor is a stepwise progression. The process described up here in this slide is applicable for these solid tumors. So it starts with a mutation. That's that carcinogen getting in there, causing this mutation. Then there's the hyperplasia, which is the normal, but too many of the cell. Metaplasia is the change from that normal to an abnormal. Dysplasia is that abnormal growth. So now it's an abnormal cell and it's growing uncontrollably. The carcinoma in situ is a localized abnormal growth, which a lot of these in situ ones we believe as a pre-cancer. We know it's there, we're watching it. Sometimes we do treat it, sometimes we just watch it, depends on how aggressive it appears. And then lastly, we have the cancer. We have a malignant tumor. Its ability to invade the surrounding tissues, the surrounding vasculature, outside of the tissue. And so this is really a nice description of the progression of cancer. Understanding the different stages and grading that is associated with tumors and cancer is important, but it's also important to recognize that there are other type of staging systems or staging graphs that are out there for different tumors. For example, blood cancers, that type of cancer, it doesn't grow into a mass typically. And so that one, you can't really stage it how we had just explained. Another type of staging is the TNM staging. This one I see a lot of times specifically with breast cancer. So this one, TNM staging, is somewhat self-explanatory. T for tumor, N for node, M for metastasis. So On the following slide with my example for breast cancer TNM staging, I like the imagery and the photograph of this one because it really does show, the tumor size where a T1 is a very tiny tumor. It's less than 2 centimeters versus the T4, which is going through the chest wall. The N for the nodes shows N0 being no lymph involvement versus how far the cancer goes into the lymph system through those nodes. And then the M is the metastasis. So the M0 is for none, and then the M1 is for a distant metastasis. So through all of these understandings of the carcinogens, the carcinogenesis, the risk factors, the diagnostic tests, the laboratory tests, the different staging, all brings us to what our goals of cancer therapy is, what our goals of cancer treatment are. And that really leads us to 4 different areas, if you will. The prevention, which is we want to avoid exposure to the carcinogens. We want to promote health. We want to do those scans, those self-screens, self-breast exams. We want to make sure that we prevent any cancer from developing. We then have the cure, which is to eradicate the disease, to destroy the disease, cure someone so they no longer have cancer. Then there's the control. A goal of cancer therapy is to control the disease, keep it where it is, keep treatment going so that it extends the life and prevents the growth of cancer cells without achieving the elimination of the disease. And then there's palliation. That one is a symptom management. That is an integration of different therapies that address the multiple issues that cause suffering in patients with cancer and their families. And so very quickly, I just want to go back and touch on the prevention aspect and how that can actually be cut down into 3 smaller sections. With prevention, we have the primary, the secondary, and the tertiary types of prevention. With primary prevention, that's where we want to make sure to avoid any type of carcinogens, any type of carcinogen exposure. And specifically, that would be things like avoiding tobacco products, using tobacco products, being exposed to secondhand smoke. Another example could be immunizations against HPV, because that is a known carcinogen, a known thing that can cause cancer. The secondary prevention, that is where we think of more of the early detection and treatment of cancer. And then the tertiary, that's when we're monitoring for and or preventing the reoccurrence of the original cancer or any secondary malignancies. So the tertiary prevention, again, that is when we are looking to prevent a cancer from coming back after they have already had it once. So goals of cancer therapy are very important to remember, to think about, because that leads us into what are the different types of treatment that we want to give these patients. We want to think about our goals, and then the doctors, along with the patient and ourselves, the nurses, help to decide what the treatment is going to be. For example, if the goal of therapy is to cure the patient, then we want the disease to be completely eradicated. That would be more of an aggressive type of treatment. Could be radiation, could be surgery, could be chemo. If we want the goal of therapy to be to control the disease, that might be more of a maintenance chemo or an immunotherapy. And then if we were just hoping for a palliation, if we just want some symptom management, that's when we might do other types of pain control, radiation. Rarely is chemotherapy used for that, but it could be. But the more in-depth discussion of these types of treatments will be in our next class. So I hope through this entire 40 minutes of this lecture, you were able to understand and take in all this information. And again, as always, if you have any questions, please reach out to me via email. I'll be sure to get back to you as soon as possible. And I look forward to actually seeing you all in person at our next class session. Thank you.